This is great, guys. So, I think kind of piggybacking off of the last two talks, which focused a lot about serology, starting with serology for screening, and then further testing, including serologies to check for persons who you identify through screening as being surface antigen positive. The next sequence in our talks, which we're going to focus on today, is what we do now that we have all of that information and data collected about serologies and testing in somebody who's infected with Hep B, and how do we take that information and translate it into a management plan. So we're going to really focus on the areas of describing new and emerging therapies fit into the current treatment armamentarium and treatment paradigm, and also evaluate individual patient cases to identify which patients need to be referred to specialists. So I think we all recognize that people are going to have different levels of comfort managing this, but did want to spend the talk today really talking about how we would manage somebody once we've identified them as having hepatitis B. All right, so going back to our 28-year-old woman who was born in the United States, her parents emigrated from Taiwan 2 years before her birth. She was screened for Hep B. She tested hepatitis B surface antigen positive and core antibody positive. So that means that she is infected, as we've discussed in the prior talks. And so then that leads you to do some additional testing, as discussed last week. And what you find is that her core IgM is negative, so you don't think this is acute infection. Her E antigen is positive. Her E antibody is negative, right? And you only expect one of these to be positive, E antigen first, transitioning to then losing your E antigen and developing E antibody. We have her Hep B DNA viral load, which is 450,000 international units. And her ALT is 12. So the question is, now what? So let's come back to this case towards the end. But I'm just going to start by our public health service announcement here, to always kind of keep this in the back of your mind that, we know hepatitis B is preventable through a highly effective vaccine. So in patients who have been identified where there's an opportunity to provide protection or prevention through a vaccine, it's really good for you to know about a 2-dose and a 3-dose series that we can give to patients. And really the hepatitis B vaccine is really the first vaccine preventable cancer, because remember, hepatitis B is oncogenic and leads to almost half of the cases of liver cancer worldwide. So by preventing Hep B infection through vaccines, you can prevent HCC. There's a C missing there, Rachel, that we can fix. Okay. All right. And so now we want to talk a little bit also about when is the right time to refer to a specialist. Excuse me. So the referral to a specialist really based, as I mentioned at the top of this talk, based on where your comfort level is. And I know that we have a lot of primary care-based learners with us in this series, some specialty learners as well. And so what the most important thing to recognize is that once you've screened somebody and they are surface antigen positive, which by definition means they have active infection, those patients need to be managed for Hep B. And typically, most of these people are going to be in that 6 months of being positive, right? You might see some acute cases that then lose the surface antigen and become cured, but the vast majority of people who you're going to screen in your practices are going to be people who are chronically infected. And so these patients not only need to be managed for Hep B, but need to be managed lifelong, really, for their hepatitis B. Hepatitis B treatment should be considered we're going to talk about this in more detail, in both E antigen or E antigen positive or E antigen negative patients, to really reduce their chance of developing those long-term late complications of cirrhosis and liver cancer that can develop in people who are chronically infected. And patients who are not on treatment should still be monitored regularly with blood work, typically every 3 to 6 months, and liver cancer screening with ultrasound every 6 months if they meet criteria. And we're going to talk about what these criteria are and who falls into these categories and when. So let's start with kind of what the goals of Hep B therapy are. So the currently available hepatitis B antiviral therapies are not curative therapies, okay? So they are therapies aimed at improving survival and quality of life, preventing the risk of disease progression, reducing the risk of developing liver cancer or HCC, preventing mother-to-child transmission, preventing Hep B reactivation, both of which these two topics, mother-to-child transmission and reactivation, are going to be discussed in next week's talk. The case, though, that Taryn, thanks again for submitting, relates to this reactivation issue. So we're going to touch on parts of it today and then probably take a deeper dive into it next week. And then prevent and treat, less commonly seen Hep B-associated extrahepatic manifestations. There are some kidney-related manifestations, skin-related manifestations that you can see in patients infected with Hep B that are a bit outside of the scope of what we're trying to tackle in this series here. And then really the goal of treatment, because it's not curative therapy, is at this time is long-term suppression of viral replication. Okay, so the way that we determine this is by measuring the Hep B DNA PCR on somebody who's on antiviral therapy. Okay, and that's typically reported in IUs per ml or copies per ml. We talked last week that there's a conversion factor between IUs to copies, which is around 5.3. So every 1 IU translates into about 5.3 copies per ml. So, but you'll see different tests use these different units of measurement, but the Hep B DNA is what we really look for, and to see if that goes to not detected in terms of what you're trying to achieve with antiviral therapy. The other things you can look for are normalization of your ALT test, which can be kind of a surrogate for viral suppression. And the other things you are always going to be looking for in somebody who is or is not on treatment is what happens to their e antigen status over time. Some treatments have a higher rate of inducing e antigen loss, and that's what we call seroconversion. So you lose e antigen and you'll typically develop e antibody. And then kind of really the best possible outcome, which is very uncommonly seen, that can happen spontaneously or on treatment, but with higher rates with treatment, but still at very low levels of like 3%, is the loss of surface antigen, which would then tell us that they've actually had an ability, either spontaneously, which happens again in less than 1 to 3% of patients per year. They've had immune clearance of the virus, and that's also referred to as seroconversion. All right. So what we're going to really focus much of the talk today on, the first part is going to be about like, how do we take all of that data we collected in the last 2 weeks of talks that we've discussed in terms of serologies and fibrosis assessments, and how do we package that into a management plan and determine who should be treated now and who can be waited, who can we wait and monitor further. So the decision is based for treatment on your Hep B DNA level, your ALT, the degree of fibrosis, which is what we mean by liver disease here, and the risk of complications. The general kind of people we think about treating are certainly anybody with clear-cut cirrhosis or liver cancer kind of automatically falls into a category of people who should be recommended for treatment to try to really reduce their risk of decompensating with their cirrhosis or having worsening of their progression of their liver cancer. So that's independent of your level of DNA. And then generally patients who are in e-antigen positive patients, if their Hep B DNA viral load is more than 20,000 IUs, but this still depends on your ALT and fibrosis assessment, and the threshold becomes lower in somebody who's e-antigen negative. So just think of like, if you're e-antigen positive, your Hep B DNA threshold at which you start treatment is generally higher than in somebody who's e-antigen negative, in which your Hep B DNA, your threshold is, for initiating treatment is at a lower Hep B DNA threshold. And then you want to consider really treating anybody who's got evidence of advancing fibrosis. So let's say you're following a patient over time. You have something called a FIBROSCAN machine, which we'll talk a little bit about in the context of this case that Taryn submitted later today. And you can use that as a non-invasive way to measure how much fibrosis is changing over time. So let's say you have a patient who starts out as 0 to 1, and then over 5 to 10 years, maybe then goes to a stage 2 based on that assessment. So anybody who's showing kind of advancing or progression of fibrosis is somebody who generally you can consider for treatment. And then certainly anybody who's got a family history of a first-degree relative with liver cancer, and then in some immune tolerant individuals above an age threshold. So let's kind of put that all into like, okay, what cutoffs do I use? How do I really make sense of this? So we're going to start with your Hep B surface antigen positive patients who are also E antigen positive, okay? And we'll start here and then we'll move over to what we do with the E antigen negative patients. So we first kind of, this is a nice kind of, algorithm slide to refer back to. So you have, access to these slides well after this talk. A lot of people do not memorize this information. You can just kind of come back here and refer to refresh your memory about when should I think about treating, which is highlighted in the areas in purple. Who I do not need to treat, which is highlighted in areas of blue on the slide, but then gives you parameters around how often to see the patient and monitor them and with which tests at what intervals. And then kind of the gray zone of people who might be kind of in between some of those clinical phases we spent some time talking about the last 2 weeks, that may suggest that people are developing more advanced liver disease or progression or change over time. And those people are highlighted in gray. So I'll just start by pointing you to the bottom of the slide, which really talks about ULN stands for the upper limit of normal. So they've done all these studies looking at what is a real normal ALT level in healthy adults. And actually, there's different ranges for men and for women. But as you will often know in your clinical practice, when you send a comprehensive metabolic panel or a hepatic panel, you just have one reference range. It's applied to both men and women. And the reference ranges are typically much higher than, a 33 upper limit of normal cutoff. So I think the assay we used to use here at Mount Sinai several years ago was the upper limit of normal was 54, and now it's actually been reduced down to 45. But you can tell that based on what we know in healthy adults, an ALT of 45 is actually much higher than what we find in average healthy adults. And so for this reason, the AASLD, which is the Professional Liver Organization, has, and there have been really good studies to look at ALT in different populations, kind of established cutoffs that we use in terms of what is really the upper limit of normal for a man and for a woman in our population. So it's 35 in men, and in women it's 25. Okay, so you start by looking at your ALT level in somebody who's E antigen positive, and you want to see, is this person below these cutoffs, in which case it'll take you down kind of the pathway on the left here. And then the next thing you want to do is look at what their DNA level is. And if their DNA level is greater than 20,000, because their ALT is normal, these are typically patients who you can monitor and not treat right away. And you want to monitor the ALT and the Hep B DNA levels every 3 to 6 months. And what you're really looking for is whether or not the ALT particularly goes up over time, which would then put you into a category over here. And then again, in women and men, you just use these thresholds. And then if, let's say your ALT is above the upper limit of normal, but not quite 2 times the upper limit of normal. So they've established these cutoffs because we know that the higher your ALT is, the greater the need for treatment and benefit with treatment is. So if you're between 70, let's say 35 and 70 for a man and 25 and 50 for a woman, you would fall in this category. And if that's where you fall, then you look down to the box below, and what you see is if your Hep B DNA is greater than 20,000 IUs per liter, you're going to want to really make sure that you've excluded other causes of the ALT elevation to make sure that, there's no other concomitant liver disease like fatty liver disease. You've screened them for Hep C. And then what you want to do is, this is where your fibrosis assessment really comes in handy. And so if you have access to something like a FIBROSCAN, which we'll talk about, that's a nice non-invasive test that some people can do in the office. The most invasive test that we have to offer patients is actually a liver biopsy, which used to be the way we used to assess fibrosis, quite frankly, in patients who fell into this category. And it was always really a challenge for us because we were trying to figure out the timing, the best timing to do a liver biopsy, because if you do it and it doesn't show much fibrosis, when should you think about repeating it, if any? So these non-invasive markers are nice because they don't really have many risks associated with them. They're safe, they can be done serially, they can be, and numbers can be followed over time. Now, if you're, and then the other things you can do for non-invasive testing is you can calculate things like FIB4 and OPRI scores to make sure you're not dealing with somebody with cirrhosis or advanced liver disease. And they've kind of been validated for different disease states. Now, anytime you do any kind of testing for liver fibrosis to really figure out what the liver disease severity is, you're looking to see if you have information around fibrosis being greater than stage 2. So the stage that most people follow is a scale of 0 to 4, this HBsAg scale. It's modified. There are many different scales that actually can be used, but the most common one is the 0 to 4. So if you're stage 2 or higher, that certainly suggests, even without any prior data in a patient, that this patient, they've already gotten to stage 2 fibrosis over whatever period of time they've had this virus. So these patients we know are at highest risk to continue progression over time. And so these patients, again, if you're making sure that there's nothing else that's reversible or treatable in terms of another liver disease, you would consider moving this person into a recommendation for treatment, because these are the patients who are at highest risk because they're already at stage 2 or higher to then progress over time. And then in your patients who have an ALT level, in men, certainly if it's greater than 70, women, it's greater than 50, and your Hep B DNA is elevated to 20,000, more than 20,000. These are the people, because the ALT is a nice surrogate for more progression activity and being in one of those clinical phases towards the right with more active hepatitis and progression to fibrosis. These patients fall into the treat now category. There are some caveats in terms of like your Hep B DNA level being at lower levels, so between 2,000 and 20,000. You could be theoretically in a seroconversion phase of this virus, and so you want to monitor these patients every 1 to 3 months, and if it persists for more than 6 months, they fall then into a treat category, a purple category. And the same thing here in those people who have raised ALT levels. Now, somebody has mentioned, when you monitor and wait for treatment, how is the follow-up compliance with patients? That's a really good question. It really varies based on your patient population. What are the barriers to engaging them in care? For some people, I always try in that very first visit with a patient to say, this is something we can manage. It's a silent disease, and unless we are kind of serially seeing you and managing you and evaluating to see how things are shifting or changing over time, because this is mostly asymptomatic, we're not going to know if what's going to happen over time, and that you are at risk, some level of risk, to progress over time. So certainly, even if you fall into a category where I'm saying we don't need to treat you now, the only way I'm going to know if that changes over time is if we bring you back periodically and assess these things to see if things are changing or evolving. So I hope that kind of answers your question. The other kind of part of this that is really important to realize is that the treatments that we have currently are, as I mentioned, they're not curative therapy. They're really aimed at suppressing the Hep B DNA virus load in the blood. And so once we start it, we recommend that these patients continue it lifelong unless we fall into a lucky category where they lose E antigen and or they lose surface antigen. And in a subcategory of these patients, and I'm going to show you this, you can stop therapy and monitor them So there are a lot of factors that go into really consideration when you're having that one-on-one management plan developed for a patient. If this is a patient who's not very adherent to keeping appointments, taking medicines, I think that has to factor into your decision about. Certainly you can recommend treatment, but realistically, if a patient's saying there's no way I can really be adherent with taking one pill once a day for the rest of my life, that should give you pause to say, really, is this then the best strategy to pursue for this patient? Because what you don't want to have is interruptions in treatment. That can lead to flares. It can also lead to resistance over time. And so then our therapies become more challenging to offer in patients who develop resistance, but I'll talk about what we can do in those patients. Okay, so I talked a little bit about e-antigen positive patients. So what do you do for those patients who are e-antigen negative? So again, looking at your ALT level using the upper limit of normal threshold cutoffs of 35 for men, 25 for women. If your ALT is in that normal range, your Hep B DNA level will start kind of here, less than 2,000, you fall into a do not treat right now category. But you want to be monitoring these patients with ALT and Hep B DNA levels every 3 to 6 months and your surface antigen once a year. And if those things change over time, then you will see kind of how you would move them into a different arm of this algorithm, if you will. Now, if somebody has a Hep B DNA, somebody who has a normal ALT who's e-antigen negative, has a Hep B DNA level that's greater than 2,000 IUs, what you want to do is go back to your kind of gray zone box here. And what you want to do is really look at that ALT, monitor it every 3 months along with the DNA level, see if things change. If the ALT does become elevated, make sure is elevated, then you want to really exclude causes of liver disease. So that'd be kind of over here. And you want to see if things change over time that would, either keep you in a do not treat threshold or move you into one of the other arms in the algorithm. Now, if your ALT is above the upper limit of normal, but not quite 2 times the upper limit of normal, again, these DNA thresholds can be looked at and monitored over time to see if then you change into an arm, particularly to the right, where if your ALT gets above 2 times the upper limit of normal, so more than 70 in men and more than 50 in women, and your Hep B DNA level is greater than 2,000, that would then put you into a treat category. So again, the thresholds at which in your e-antigen positive and e-antigen negative patients are a little bit different. And again, a key factor here is what is your ALT level and what are you seeing if you're in a gray zone with respect to the degree of liver severity as measured by fibrosis, or if you have a biopsy necroinflammation, or how much severe inflammation is going on in that biopsy. All right. So why not treat everyone with Hep B? I guess theoretically, yes, you could adopt this strategy. It's not practical for cost reasons. A lot of these patients are infected as infants at the time of birth. And so committing patients to lifelong therapies even earlier in their lifetime, when there isn't really clear benefit in terms of reducing the risk of progressive liver disease, reducing the risk of developing liver cancer or liver cirrhosis. And the limitations of current therapies, again, are that they do not offer a cure to our patients, at least the currently available ones. But I'm going to talk a little bit about how this landscape is shifting. And so in our lifetime, I actually think with some of these newer therapies that are still in clinical trial and developmental phases, I'm very hopeful we might find a cure for curative therapy for Hep B. So long-term treatment is needed, and you need to be monitored on treatment. And so, as I mentioned, there's not a favorable cost-benefit ratio to treating everybody. And then there are some implications for drug resistance, particularly with some of the older treatments that are no longer considered, top or first line. So how do you, if you do fall into recommending the patient does not need treatment now, how should you manage these patients and monitor them? Here's a nice slide for you to refer back to in your e-antigen positive patients. If you're less than 30, you want to follow them every 3 to 6 months. This kind of illustrates to the right what tests and at what intervals to check them. Again, it's a combination always of your ALT, your Hep B DNA, and reassessing liver fibrosis, kind of over time. And then, checking the surface antigen and the e antigen at least annually to see if something changes. In e antigen negative patients, which kind of are the two categories here, based on your Hep B DNA level, you will follow the patients every 3 to 6 months. Again, checking your Hep B DNA level 6 to 12 months. And if your DNA level is higher and you still don't meet criteria for treatment, you want to see if they're in that potentially zero kind of conversion phase and follow them a little bit more intensely for the first year, and then you can space it out to every 6 months. Again, checking your ALT and your Hep B DNA and periodically your surface antigen in these patients. All right, so moving kind of from how you come up with treat now and monitor, don't treat now, but monitoring plans, let's start talking about some of the antiviral therapies that are currently approved. So what we've highlighted here are all of the FDA-approved therapies for Hep B. The first-line drugs are displayed in green. So these are the kind of first medicines that we would recommend for patients. And you'll see that includes entecavir. So the brand names are over here. Tenofovir, we now have tenofovir alafenamide, which is also called TAF, Vemlidy, Viriad, Baraclude. And then pegylated interferon is actually still considered a first-line therapy, although it's very rarely given in clinical practice. And patients actually tolerate it much better than what we think of when we think of pegylated interferon more commonly with old Hep C treatments where it made patients much sicker. So what we've learned over time is that the reason why our first-line therapies are first-line is because they have the lowest rates of resistance. So actually the oldest therapies, lamivudine followed by dafavir, many years ago used to be our quote-unquote first-line therapies, but what we found that administering them to those patients who met criteria for treatment now and then following them over time, actually we found a lot of resistance in patients who had been on therapies for more than 3 years with these older medicines. And so that's why we recommend because of the lower rates of resistance, to start with one of these first-line therapies. And then, as I mentioned, interferon is really very rarely used these days because of convenience. And, here in the United States, patients certainly prefer to take a pill rather than usually take an injection-based therapy weekly for, 48 plus weeks. And so the rates of resistance with these first-line therapies are exceedingly low, 0 to 1.2% based on studies that have been done. So what are the kind of pros and cons to taking the pill-based therapies, which fall into the category either of a nucleotide or nucleoside agent, versus the injection-based therapy of pegylated interferon, which, as I mentioned, you probably have not really come across many individuals who have either been treated with this or providers who are actually prescribing it. And as I mentioned, oral administration makes the oral antiviral therapies more attractive for a lot of our patients. It's typically well tolerated, again, resistance isn't so much an issue with the first-line therapies that we have now approved, but certainly was an issue with some of the older treatments. The duration here is lifelong with the oral therapies. The long-term safety for the data that we have so far looks pretty good, but it's not like some of these newer therapies have been around yet for decades for us to know what happens in 20 or 30 years of clinical use. Pegylated interferon is a very old medication. You typically will treat them for a finite duration of usually more than a year. Some patients can have a sustained response. What we found is that even though the Hep B DNA level might remain undetected off treatment, you really want to make sure that they've lost surface antigen, which I'll show you what the data looks like with different therapies. What's the rate of surface antigen loss? Some of these people then sero-revert, so they go from being surface antigen positive, you put them on interferon, they lose their surface antigen, and then over time the surface antigen can come back in some of those people. So that's also made it a pro and a con, I would say. There doesn't seem to be any resistance involved with pegylated interferon. It is an injection-based treatment, so it involves education, patient adherence, and willingness to accept taking an injection-based therapy. Side effects are more than the oral antiviral therapies, but as compared to patients with Hep C, much better tolerated. And it is contraindicated in certain patient populations, including pregnancy, cirrhosis, and in post-transplant patients because of drug interactions. So how do the treatments stack up with respect to some of the things we look for on treatment? So what you see here in kind of black is what happens to Hep B DNA levels, and in gray, Hep B surface antigen levels on just pegylated interferon. And what you see is you have a nice decline in both the DNA and the surface antigen level at your end of treatment benchmark, and then you stop treatment, and what you can see over time is that the Hep B DNA level can rebound or come back. They've also tried adding lamivudine to pegylated interferon, and you again have these nice robust drops in the DNA and the surface antigen titers, but they tend to also come back post-treatment 6 months later. And in patients who are treated with, and these are old studies, so this was based before we had our newer first-line therapies. But when we just had lamivudine as our top-line therapy, when we looked at that, it did a very nice job of dropping the Hep B DNA level, but not as great of a job with the surface antigen level. So what this tells us is that you have higher rates of actually surface antigen loss with interferon-based treatments, no real benefit when you add an antiviral to that. But there is high rates of surface antigen coming back up off of treatment, even with interferon. So for some of the gains, there can be like some consequences with them, the surface antigen coming back even after treatment. So again, another way to try to compare different therapies. So you have your pegylated based therapies. This gives you the dose. This is an E antigen positive patients and kind of tells us what's your rate of losing E antigen and seroconverting and developing E antibody. So very high rates with interferon based treatments compared to the nucleoside and nucleotide analogs. These are the oral therapies. Lamivudine is LAM, tilbibudine is TBB, and entecavir is ETB. The ADV is adefovir, and TDF is tenofovir, and tenofovir alafenamide is TAF. Rachel, I just realized it might be nice to actually include some of the abbreviations at the bottom of the slide in case people don't remember it from the slide before.
Okay, sure.
Yeah, so we can maybe add a little box there. Yep. And then what happens when you look at Hep B DNA suppression, because that's really the goal of treatment. So you have you can have Hep B DNA levels that get suppressed at lower rates with interferon compared to these oral antiviral therapies. And this is again looking at patients and how they do over time. So you have the highest rates of Hep B DNA suppression with entecavir, tenofovir, and also now TAF. And then that's followed by talbivudine, lower rates with adefovir, and lamivudine are older drugs. And then when you look at ALT normalization, another thing you're looking for in your treatment, again, the highest rates are with your top-line, first-line therapies of TAF, tenofovir, and entecavir. And then I mentioned earlier that you can sometimes induce surface antigen loss, which would be a great thing to see. And that's more commonly seen with interferon-based treatments, but then we know once we stop treatment, these patients still need to be monitored, and they have, unfortunately, 40 to 50% of them will have surface antigen that comes back, or serorevert. With the oral antivirals, I mentioned, it's anywhere from 1 to 3% surface antigen loss over time. And it looks like it's the highest with tenofovir, followed by entecavir and TAF. So things to keep in mind when you're selecting your antiviral therapies and thinking about how these things compare to one another. All right, so and in E antigen negative patients, we really can't follow the loss of E antigen because they're already there, so they're E antigen negative. And what you can see is how interferon-based therapies, again, where you have much higher rates of surface antigen loss, but once you stop therapy over time, up to 40 to 50% can develop surface antigen again. You have very high rates and good rates of viral load suppression with that DNA PCR test, and high rates of ALT normalization in E antigen negative patients. All right, so kind of how do you select in the first line therapy category one drug over another? And this kind of gets back to, you know, our discussions and how we tailor them to our patients individually. So, so indications for selecting either entecavir or tenofovir over tenofovir alafenamide over tenofovir. Well, in patients who are over the age of 60, and that's because they have higher rates of pre-existing or subclinical bone disease and renal disease. We know that tenofovir has higher rates of osteoporosis and chronic kidney disease over time. So in these categories of patients, you want to always think about selecting entecavir or TAF. TAF was developed because it's a prodrug of tenofovir, and it has better kind of plasma delivery of the actual prodrug or of the drug, and it has less toxicity. And so it was developed to really overcome this issue that we were seeing in patients having accelerated osteoporosis and chronic kidney disease. So these patients off the bat, you want to think of one of these entecavir or TAF over tenofovir if you have patients that meet these criteria. And again, when you're having your one-on-one discussions with your patient, you're really trying to explain or convey that the whole goal of treatment is to really is to try to take your train that's left the station, if you will, and put things in reverse. So let's say you've identified somebody with a raised ALT, you've met their DNA threshold, they have, you know, stage 2 fibrosis or higher. We know that over time, particularly if they have additional things that can accelerate fibrosis, such as metabolic factors, we are at risk in these patients for developing advanced fibrosis, cirrhosis, and higher rates of liver cancer. So if we identify these patients who meet these criteria and we start them on antiviral treatment and we can suppress the virus, we know that we can kind of move this train that's left the station and hopefully halt progression or reduce the risk of progression of disease, and sometimes even move things in the opposite direction and actually have some regression or improvement in fibrosis scores. We have seen some patients go from being decompensated cirrhotics, and if we can get them enough time on treatment, we've seen some real successes with developing compensated disease and even non-invasive tests that show us that cirrhosis doesn't seem to be present. Now, what kind of monitoring do these patients need who are selected or recommended for therapy? Well, ALT and Hep B DNA needs to be monitored at all patients who are on nucleoside or nucleotide based therapies. Kidney monitoring, particularly with starting it with at least the GFR and serum phosphate levels in patients who are at risk for renal disease, who already have some pre-existing chronic kidney disease, and you're thinking about starting on any nucleoside or nucleotide treatment. And then in those patients who don't have any existing renal disease, who are not above the age of 60, who don't also have bone disease, who you select for tenofovir-based therapy, you need to monitor the renal disease on therapy, or renal function on therapy kind of lifelong. And then kind of other things to be thinking about in your patients who you're managing for Hep B is, you know, you want to think about liver cancer surveillance. And it's really mandatory, certainly in any person who has cirrhosis or who seems to be at higher risk because they have like a first-degree relative who has a history of liver cancer. And that screening, which we're going to talk about, is generally done with ultrasound plus or minus an alpha-fetoprotein every 6 months. So when, if any, can you stop therapy? The general thing I actually tell most patients before we actually embark on starting therapy is that for most people, I'm going to recommend lifelong indefinite therapy. Now, this may change with new therapies that get approved if they do show the promise of curing patients, but for most patients, it's going to be lifelong therapy with an antiviral. Now, oral antivirals can be discontinued if you confirm surface antigen loss, and this can be with or without developing that protective surface antibody. So, and it may be discontinued in people who are e-antigen positive who don't have cirrhosis. So anybody with cirrhosis should continue. who achieve e antigen loss and have an undetectable Hep B DNA for more than 12 months. So that 12 months is what we call consolidation therapy. So you really want to make sure that you've suppressed the virus, you've seen a good response, they've now cleared the e antigen, and you can ensure close monitoring off of the nucleotide or nucleoside agent. So if you're somebody you think is at high risk of not being able to adhere to coming back and monitoring to see what happens to their DNA level and e antigen status over time, this would not be a good strategy. And then in selected e antigen negative patients who also, again, do not have cirrhosis, who have achieved a very long-term virological suppression with their Hep B DNA being undetectable for more than 3 years, you can consider those patients potentially to stop treatment if you can guarantee, again, their monitoring off of treatment. So again, if you've lost your surface antigen, yes, you can think about stopping therapy, and you should. In those patients who are e antigen positive or e antigen negative without cirrhosis, you have to either have consolidation for 12 months or essentially 3 years in the e antigen negative patients, and then be able to monitor them off therapy. This just kind of gives you a sense of resistance with different therapies. Lamivudine, over time, we've seen really high rates of resistance to Hep B, with Adefovir over time as well, and the different colors represent different years of treatment. And then what we've seen with the first-line therapies is entecavir does have this up to 1.2% level of resistance reported after year 3 through 5. And with tenofovir and TAF, there's been no reported resistance in following patients out for several years now. What do you do if you do have a patient where the viral, they're telling you you're taking treatment, but the virus level that you're monitoring, the Hep B DNA, comes up from undetectable to a detectable range over time? Well, one, you always want to ask, are you really taking the medicine consistently? Are you not missing any doses? And then the second thing you want to do is you want to check a Hep B resistance panel, which can sometimes be done by actually ordering a Hep B genotype, and then they run the resistance panel with it. And what you want to look to see is if they've developed resistance to various variants here. And if they have, it'll tell you that they've now developed clear resistance if they fall into, let's say you have somebody who's on, let's say, tenofovir treatment, and again, there's no reported resistance here, that's why there's nothing here in red. But let's say you have somebody on entecavir who develops an M204 resistance on the resistance panel. Then you know that this is somebody who, entecavir is not going to be a good treatment potentially going forward. And so what do you do in those cases when you develop resistance to various agents? You can switch them, and this is a nice slide to just kind of keep in your back pocket and think about coming back to, if you do develop resistance and you send the resistance panel, if you're on which a certain agent, what agent should you switch to or change to or add? All right, so let's now kind of go back to our cases. So we have the 28-year-old woman born in the United States. Her parents immigrated from Taiwan. She's got Hep B. She's E antigen positive. Her Hep B DNA is 800,000 and her ALT is 44. So what do we want to do here? I can go back to the slide. So her ALT, what do people think about her ALT? Let's open it up to discussion really quickly. Is that a normal ALT for a woman? And feel free to use the chat box. So what did we say was the upper limit of normal for a woman? So I think someone's typed in. Yes, so they're above the upper limit of normal, but they're not quite 2 times the upper limit of normal. Yeah, so it's elevated, as Joanne said as well. And it's 25, Denora says. Correct, so you guys all caught all of that. So they would kind of be in that middle algorithm of somebody who's e antigen positive. And then let's just go back really quickly. We would go back to see what happens with their Hep B DNA. And as one of you, the first person mentioned here, you would be in this gray zone where you'd be monitoring them every 3 months for a year to see if they're in this phase of changing. And if the ALT flips into, greater than 2 times the upper limit of normal, then yes, if that DNA level is still in this range, you would automatically fall into a threshold of treating. The other person to think about is if you're staging them non-invasively with serial FIBROSCANs, or you have a biopsy on this patient and it shows severe necroinflammation, which is A3, or fibrosis level of 2 or greater, that would also recommend, put you in a category of recommending this person for treatment. Okay, so great. All right, so let's now, sorry, I think I went through too many slides here. Okay, so that's that case. Let's go through the rest of the slides, and then I want to go to Taryn's case if we have time this week. I think it's a nice one. So we have this case, so non-cirrhotic, so who should you be screening for liver cancer? So non-cirrhotic patients are at risk for liver cancer, so Hep B is oncogenic, as we discussed. And it's likely related to DNA integration into the host genome, causing, insertional mutagenesis and turning on cancer-related genes. The threshold for screening in Hep B without cirrhosis occurs when your annual incidence of liver cancer is 0.2% or higher. And they come up with guidelines that take into account cost effectiveness relative to life years gained. So how does this break down into what you practically recommend for patients? We know that Asian women and men and Black men have higher rates of liver cancer. So the threshold for liver cancer screening in somebody without cirrhosis, right? Because anybody with cirrhosis, you should be screening them with an ultrasound plus minus an alpha-fetoprotein every 6 months. But let's say you don't have cirrhosis and you're an Asian or Black man over the age of 40, or an Asian woman over the age of 50, you're recommended for liver cancer screening. If you have a first-degree relative who has a history of liver cancer, you're recommended for screening for liver cancer. And anybody over the age of 40 with persistent or intermittent ALT elevation and or your Hep B DNA levels greater than 2,000 IUs per ml. Screening is recommended with ultrasound examination with or without alpha-fetoprotein every 6 months. The one caveat in the AASLD guidelines is that for people living in areas where ultrasound is not readily available, screening with the alpha-fetoprotein every 6 months should be performed, but it is considered suboptimal to doing the ultrasound every 6 months. Okay, so the AASLD guidelines, as of 2017 for cirrhotic patients, all cirrhotic patients are recommended for liver cancer surveillance because it improves overall survival. The AASLD suggests surveillance using ultrasound with or without alpha-fetoprotein every 6 months. The AASLD suggests not performing surveillance of patients with cirrhosis who have decompensated cirrhosis who are on Child-Pugh Class C, unless they're on the transplant waiting list because of the benefits of survival being very low in patients with Child C cirrhosis. And AASLD recommends diagnostic evaluation for liver cancer in patients who have ultrasound testing with either a multiphasic CT, so a contrast-enhanced CT, or an MRI to look for diagnostic characteristics on those contrast-enhanced studies. Okay, and then just a couple of slides here to talk about new therapies that are being developed and looked at but are not ready for prime time, not approved yet, but are being centers, big centers that are participating in trials are recruiting patients to try to develop these drugs a little further. If you kind of think about the Hep C paradigm, it was actually by recruiting patients into trials that we got all of these nice new treatments for hepatitis C approved as of 2014 that now cure patients at very high rates. So these new treatments are really looking at not just viral suppression, but achieving a cure. And the really tough part about Hep B that's different than other liver diseases, particularly even Hep C, is that the Hep B virus actually integrates through this covalently closed DNA, cccDNA, into the host genome, making it harder to get it out of the system and cure patients. So we're looking at new biomarkers or new targets for therapy, cccDNA. We're actually looking at antigen levels, Hep B RNAs, which have a strong correlation with the presence of integrated DNA into the host genome. And future treatment options for Hep B are really looking at novel targets and immunotherapeutic agents. And as I mentioned, they're kind of in different stages, but mostly preclinical and early clinical trials, so phase 1 and 2 trials. They are also looking at combinations of antiviral and immune modulatory therapies targeting multiple steps in the Hep B life cycle. And future treatment options are also being looked at for those people who are co-infected with Delta. and clinical trials for that are open. So just to give you a sense, think of everything here in black as kind of part of the life cycle for Hep B, and what you see in the blue boxes are the new therapies and where the targets are. So they're looking at entry inhibitor therapy, so trying to prevent Hep B from ever entering into the hepatocyte or the liver cell. New drugs are also being developed to disassociate from the capsid, to prevent cccDNA formation, prevent transcription, to prevent viral RNA from being developed, preventing translation. So you can see just like really every step of the life cycle is being targeted now with these new therapies to figure out what's going to be the best kind of drug we can develop. These are many drugs that are in phase 2 therapies, so they're not even given names, they're given these abbreviations, and this slide is going to be changing like every couple of months that we give this talk, and that tell you kind of where their targets are right now. This is one example. There are a couple of phase 2 studies now being done with this drug, looking at core protein inhibition and really inhibiting Hep B life cycle at multiple steps to achieve a cure. All right, so I'm going to stop here. I'm going to open it up to questions, and then I'm going to talk, and then I'd like Taryn to present the case after we've taken the questions, and we'll focus on maybe screening and how to interpret FIBROSCAN results for today. Taryn? All right, so are there any general questions about management, monitoring, antiviral therapies, new therapies that are kind of coming down the pipeline or being developed? Folks can use the chat function.
Yeah, you could take yourself off mute or put it in the chat.
Okay. While we're waiting for folks to think of it, if they have any questions, I'm going to go ahead and switch over, Taryn. Which one is preferable, FibroScan or elastography? Good question. So we're going to talk a little bit about what is FibroScan, Denora, and I think that will be helpful. So give me 1 second while I pull up the case. Okay. Rachel, let me know if we're looking at the case on your screen.
Yep, we are.
Okay, great. So Taryn, do you want to take us through, you want to take us off, you take yourself off mute and walk us through this case?
All right, so this is a 61-year-old African-American male who came to me through his HIV primary care provider in the setting of newly found or diagnosed Hep B, pretty much like the day we gave him Rituxan. But we knew that it wasn't from the Rituxan that we caused an activation because his labs were drawn like right before he got it. His case is kind of interesting in that, you know, it highlights, I think, some of the importance of screening because he had been surface antigen negative, and I only put, I think, a couple of times in there where we had checked where he was negative and positive, but we had checked him a couple of times, and we'd also vaccinated him, but he never mounted surface antibody, and then he comes up to become infected with Hep B. And so anyways, we started him. He has some kidney issues. He's got this immune complex nephropathy. And so we started him on renal dose entecavir. And then we added the Vemla-D just because his viral load was really, his initial Hep B DNA was really high. So we were trying to kind of just get him down. Interestingly, I guess, speaking to the FibroScan piece, so I did a FibroScan on him and it was 6.2, which is, you know, pretty much F0, F1 range. CAP score of 292, so pushing severe steatosis, which is 300. So definitely has a fatty liver. And then I did a FIB4 on him when I initially met him, and his FIB4 was 1.4, so also not suggestive of cirrhosis. And then he finally got his imaging done. And, you know, on that ultrasound, they said, you know, he's got these nodules, but then they also said he has, you know, has cirrhosis of the liver, which I was a little surprised to see because I was like, well, all these other tests and his platelets are intact. You know, I'm not sure I'm buying cirrhosis off this ultrasound. So I guess the questions would be kind of like some of the different staging modalities. What do I think is more reliable to trust, or what do I go off of? And then in terms of the imaging study for his HCC screening.
Okay.
How to
Yeah.
follow up on that.
I think these are really great kind of places to focus for today. And as I mentioned, we're going to talk about reactivation risk next week. So this was clearly somebody who, in the period of which you were following them, went from clearly being a Hep B negative person to actually having Hep B infection.
Yeah.
And so in the context of immunosuppression, question was, how are you going to like keep the Hep B managed very well so that we didn't run into trouble, it sounds like, with immunosuppression therapy. So you always start with screening, right? And so the screening tests you were checking were what tests?
So they had been checking with the Hep B surface antigen and the Hep B surface antibody. And I had dug back really far back I got out our old records, and there was an old note from 1996 saying that he had Hep B surface antibody. And I was like, wow, maybe this is a case where he lost surface antibody. But I couldn't find the lab to back that up. But so we were pretty much checking him with surface antigen and surface antibody.
Okay. And we should mention that this is a person who's co-infected, right, with HIV.
Yes.
So that would be another reason to have screened this person for Hep B much earlier, which I assume was probably the reason why he was, tested.
And then lifestyle-wise, he is MSM, so that was the other reason too.
Okay, great. So all of those things put him into a category of needing screening.
Yeah.
And the screening was done. I'm curious, was there ever a core antibody done going back?
There was. So I couldn't find a core going back. The only core that I could find was the one I sent.
Okay. And, I think the older, again, this person's been followed in your system for a long time, and the CDC used to recommend just surface antigen and surface antibody for screening. And then over time, and I'm not exactly sure at what exact time, but it has been in the last 10 years that they shifted from surface antigen and surface antibody to also getting the core antibody now too. Okay, so then you had a patient who was negative who is now infected. Mm-hmm. So you, in addition to checking the viral load, you wanted to do, it sounds like, a liver fibrosis assessment on them.
Yeah.
So I'm gonna stop the share again, and I'm gonna kind of go back to some slides that I added for us to kind of use as a point of discussion here. Where's my PowerPoint? Hold on one second. Here we go. It's just the question slide. Okay, that's why I couldn't see it right away. Okay, so I think someone typed into the chat box, what's it, like, how does FIBROSCAN compare or change to, I'm having I think a pause on my screen here. I can't pull up the chat. Give me 1 second. I don't know what happened. But they were asking what's the difference between FIBROSCAN and elastography. So FIBROSCAN is transient elastography. You're seeing it or having access to it, I think, in ways more frequently now than we did even a couple of years ago. Taryn, in your practice, do you guys have a FIBROSCAN machine on site, or somebody does at your center?
Oh yeah, we do.
Okay.
Right down the hall.
Okay, and not everybody does, but sometimes you can find another provider who has it and actually refer them, and there's a billing code now for it, so people are starting to accept referrals for consultation just for a FIBROSCAN. Okay, here we go. I can see the chat function now. Okay, so it's actually transient elastography. And what they've done is they've validated it. So this was actually technology that was developed. I love telling the story because the person who developed it told us the story, was actually first developed using technology that was being used in the cheese industry in France. So it's actually a French company that owns FIBROSCAN. They're called Ecosons. And the whole idea was like you had these big rinds of cheese and you wanted to find out when they were ripe or ready based on what the, how elastic or how stiff they were in the center. So someone had the great idea of why don't we take this technology and actually develop it into a novel medical tool, because we are having to subject patients to biopsies. They have risks. Patients don't always want to do them. Providers don't like to do them. And so we know that the liver kind of sits on the right side. Can we develop this technology and compare it side by side in various liver diseases to liver biopsy and come up with a scoring system? And that's exactly what they did. There are different types of elastography. You can actually also do MRI elastography, where you can send somebody to a radiological facility, and if they have this technology, it uses MRI technology to actually calculate in the entire liver how elastic is the liver, and the elasticity basically translates into a fibrosis score, stiffness score. And so for hepatitis B, Taryn, can you tell me what the FIBROSCAN score was for this patient? It was 6 point. I think
Sorry.
you're on mute. Yeah.
Yeah, sorry, I just had to unmute myself.
That's
Sorry.
okay.
It was 6.2.
6.2.
Mhm.
So the way you would use this is the score is in using units of kilopascal, and the 6.2. So the score actually goes from anywhere from 0 to 75. You see on the right is a little legend for what the colors translate to in terms of a stage 0 to 4 scoring system. So what you can see is that a score of 6.2 or 4 in this patient would be in that light green. So they're in a stage 0 to 1. And now you can repeat this going forward annually, and I usually don't do it more than annually because scarring takes a long time to develop or to regress. And so doing it every visit, you're probably not going to see as significant of a change. You actually might develop more noise, if you will, with getting kind of scores that are all over the place. So I typically would recommend to do it maybe every year or longer to monitor to see what happens over time. Okay, so somebody said, any information about, pregnant women are going to be covered next week, including the therapies that are safe and effective. So I'm going to hold that question until next week, but we will tackle that. Also, which medicines are safe for pediatrics? We actually didn't include any information here. Let me see if I can add a slide. It's not actually in the slide set for next week, but we could talk about it in the context of the mother-to-child transmission, Rachel. So we can add a slide there to answer that question. And then what about this patient's Delta test? Do we have results for Delta testing? So Taryn, I don't know if you included whether or not this patient was screened for Delta virus.
Yeah, so I put that I could not get him screened for Delta because he has to go to Quest Lab to get his labs, and they won't run it. So Hopkins will run the test, but insurance won't pay for him to get tested for Delta.
Okay.
So I'm kind of like, all right, I'll just figure it out. And if I can put him in a trial, I might be able to convince them to check him for Delta.
So I would also double check the CDC website, because they used to have a form you could print out and they would tell you what top tube to draw the blood in, and you could send the test to them to check for the RNA test if the IgG is positive. So that would be check for the viral load. So, but it sounds like you're even having challenges with getting just the antibody tests checked for because of cost reasons. Yeah. What is the cost of the antibody that they're telling you? Did you find out?
I did not find out.
Okay.
So, but I could, and I don't know if Quest just doesn't draw that or if it's just not on their lab.
I don't think included on everybody's lab panel. So it is like places like Hopkins and other places that will run it. You may want to reach out to the Hopkins lab people and say you have like a patient who's worried about insurance. Is there any programs that cover Delta testing? The other thing you could ask about.
I can reach out to our head of micro. Yeah.
The other thing would be your Department of Health in Baltimore is actually really good.
Yeah.
And you can see if there's any free testing programs in the city that could cover or supplement Delta, because they would have an interest to know about the Delta.
Yeah, no, exactly. I know we do for some of our Hispanic patients, but I don't know about check with them for sure. And then just,
Eleanor, you mentioned, I'd like to highlight the importance of testing for Delta. So we would agree, because when Delta is present, Hep B DNA is undetectable, although surface antigen positive without testing. So Delanora, can you take yourself off mute? I think this would be easier rather than doing it by chat, because I think there may be some things I'm missing there.
Hello.
Hi.
Hi, can you hear me well?
Yeah, I can.
Okay, so what I was trying to say is that in some patients, HBs antigen can be positive, but their viral load can be undetectable. This does not mean that their virus is not replicating. It's just they may be having HBV or Delta virus co-infection or superinfection, and it suppresses HBV virus, therefore it gets undetectable, and the viral load is undetectable. Therefore, I think it's very important to test for HBV in all chronic HBV patients.
Yeah, so I think this is a really good point. So so definitely screening your patient populations for Delta. I think there's a national global recognition that Delta is under-recognized because we as providers aren't often thinking about it, and we're not testing for it. And then there are challenges, Taryn, as you just kind of highlighted, with even getting the test done, that even when we do think about it can sometimes make it difficult for us to do. But I think, Delanora, as you mentioned, it's a very important test to know. The clinical consequences, I think we touched upon this in an earlier talk, in those patients, actually, sorry, Delta virus is covered in next week's talk, and that was based on some of the feedback we got in earlier boot camps, that these patients can have either co-infection or superinfection, in which they can actually develop, particularly those who have co-infection with both B and D, because D is one of those viruses that you have to have hepatitis B present to be viable. You can have actually more accelerated disease course, right? So you can develop cirrhosis at a very much younger age. You can develop cancers at younger ages. And so really trying to screen is really important. And Delanora, the other thing you shared was that you said this summer Quest Lab was offering free Delta testing. So it might be worth Taryn reaching out to your local Quest to see if they have any other ways, as we just talked about, to get testing either through Quest, Hopkins, or the Department of Health, because there would be a good interest to do it.